Hello everyone, today we'll be talking about building the bone in the aesthetic zone, and I would like to start my introduction by introducing myself. My name is Dr. EHAB RACHED. I'm doing implants in Dubai. I did my first implants in 1994, and we'll be going through this lecture today to show you how to build a defect in the aesthetic zone when you have a missing bone and missing soft tissue. For any thing in our life, we have to plan and follow steps that will lead us to a final good result. And this is one slide I want to start with, is how my city in the 60s used to look like. And by proper planning and proper diagnosing and following the proper steps, you can reach a good result. As you can see here, the picture on the top right side. We implement this in our cases in the clinical situations, and we'll see how we go through steps of planning and diagnosing and following the proper techniques and ways that can lead to a good result and good final outcome. Today, this is the case we're going to talk about and discuss it in little details. As you can see on the top left hand side, a lady having missing two central incisors. And she's been wearing a RBD for a long time. We can see that on the top side that there is a big defect in the buccal bone from the buccal side, and also we look from the other side in different slide, we'll see also she has a vertical defect as well. After exactly 18 weeks of treatment and the proper planning and diagnosing, this is the final result that you can see here on the bottom of the page. As you can see, we build up the bone and build up the soft tissue, and we have a very good end result, and this can be achieved by following the guidelines and the proper steps in diagnosing and choosing the case and following up the cases properly. And we're going to go step by step and show you how to reach this kind of result. There are some factors that always influencing this kind of results, and in order to achieve this optimal results in the aesthetic zone, we have to take in our mind and consideration these three main factors. The first main factor is the gingival biotype in the defected area. As we all know, the gingival biotype is either a thick biotype or a thin biotype. Second factor is the labial plate of bone, and this is determine how much thickness we have on the labial plate of bone, and how much buccal bone thickness we have on the buccal side of the ridge. The third factor is the implant position. Where do we place our implant? In the buccopalatal direction, in the mesiodistal direction, and the epicocoronal direction. We're going to go through these factors in little details in order to reach our end conclusion and to see how we can implement this in our treatment in a clinical case. The first factor that we all know, the gingival biotype. When we talk about gingival biotype, it's always been classified as a thick or a thin biotype. In the old time, we used to look at the gingiva and decide it's a thick or a thin biotype without having any parameters. Nowadays, there's a lot of literature and studies that can give us a well definition of this kind of two terminologies, a thick or a thin biotype. So it's been proven that when you have a thick biotype, this means that we have a thickness of 2 millimeter or more in the mucosa on the buccal side of our ridge. When we have this kind of mucosa on the buccal side of our ridge, which is of 2 millimeter thickness or more, this is will lead us to a good final aesthetic result. And if the thin biotype is less than 2 millimeter, this will lead to poor aesthetic result. So this means that if we have such a thin biotype, we have to first think of thickening the biotype, thickening the gingival tissue on the buccal side of the ridge, and then we can think about doing our implants. If we're starting with a thin biotype and we don't do anything about it, will lead to some aesthetic failure and will give us a bad result of our implant case. Second factor, which is the labial thickness of bone, is being proven by a lot of studies and a lot of literature. We can see this in the peer studies, the peer journals, and lots of articles have been published about this, that when we have an implant, especially in the aesthetic zone, we need a minimum of 2 millimeter bone thickness on the buccal side, as we all know that the buccal plate of bone is very easily resorbed and usually remodeled after the loading the implants, and the same time also after extraction. This buccal plate of bone is usually resorbed very fast, and in order to maintain a good result at the aesthetic zone, we should always have a 2 millimeter thickness of bone buccally to the implant. So if we have less than 2 millimeter, this is mean that we might have some aesthetic problems in the future. After loading the implant and remodeling of the bone, there might be some resorption, and we might have some kind of metal shining or showing through the buccal area, and this is due to the thinning of the labial plate of bone. So when we do an implant, we have to measure our buccal plate of bone. If it's less than 2 millimeter, we have to augment it, and if it's more than 2 millimeter, we don't have to worry about it, but it's usually always very thin, and we always have to augment it in this area. And there is many ways to increase this buccal plate of bone, and many techniques have been discussed before in lots of studies and lots of literatures, and we have the golden rule for this augmentation is the autogenous bone, which is the bone taken from the patient himself. For this autogenous bone, we have many places to take bone from. The most common areas are the symphysis area, the retromolar area, and the tuberosity area. When we take this bone from the patient, this is patient own bone. It can be augmented anywhere, and it can be placed at any part of the jaw. One more thing is the bone substitutes. We have now in the market few companies doing lots of bone substitute material. I don't want to go through all these substitute bone material, but we have something called allogenic bone, which is a human donor, and many companies doing this. We have the Zimmer doing this, the Maxigraph doing this, the Sinobone doing this. All of them are of a donor origin from human, and usually they are freeze-dried bone, and they can be used in different places, and also they have lots of cancellous bone or cortical bone or a mix of them. One more thing is the xenogenic bone, which is originally taken from animals, like a bovine bone, such as the bio-os and the sera bone, which is a very common material that everyone is using nowadays in the dental field. And also have the synthetic bone, such as the beta tricalcium phosphate or the hydroxyapatite, like Polybone, the Easy Graft, and so on. So there's many products in the market, and there is many kind of bone substitutes that you can use. Different countries have different brands. I don't want to go through brands because every countries have their own brands that's available in the market. So in general, this is the things that we can use, either autogenous bone or a bone substitute. One more thing that I usually use a lot is the something called the auto bone collector. This auto bone collector is not an expensive device. As you can see on the left slide, it's consisting of a shank that you can mount it on a low-speed handpiece, which usually I use it with the surgical motor handpiece. It has a diameter of 5 millimeter. It has a cutting depth from 2 to 4 millimeter in cutting depth. As you can see, it has a barrel, which is the golden color, and the barrel has a stopper. When the barrel move all the way to the top, it's only show you how much deep that you went through the bone. So it's a very safe device. You can use it on a low speed, starting from 300 RPM to 600 RPM. You can use it with irrigation or without irrigation. If we use it without irrigation, I would advise you to slow the speed down to the minimum of 300 millimeter. I like to use it with irrigation to make sure that you're not overheating the bone. It's a very easy little tool that you can use. It's not very expensive. There are lots of companies doing this. The one I'm using here is from a company called Ostem. It's a Korean company, and the tool is not that expensive, so it's not difficult to get it anywhere, and usually you can use it for a few times. The company usually recommend to use it for 50 times. Sometimes I use it more than that. It depends on how much cutting you can see the collector is cutting into the bone, and you can always re-sterilize it and use it again. So it's a reusable, it's not disposable. So it's not a cheap tool that you can use it in the clinic few times. Also, one more thing I'm going to use in this presentation is something called the Smart Builder. This Smart Builder is a titanium membrane. The titanium membrane is the one you see in the middle with the holes. These holes are made in a way to make sure that the augmented area will have enough blood supply. And this titanium membrane, it usually has rounded corners. The old titanium mesh that we all used to use before, it had like a sharp edges. When you cut it with a scissor, you end up with having sharp edges that usually go through the soft tissue and cause the exposure of the titanium mesh, which is a very common complication that it was very famous for using a titanium mesh. With this one here, the company has produced a few kinds and shapes of the titanium mesh. This mesh can be used in a single defect or a two-sided defect or three-sided defect. You can go through the titanium Smart Builder membrane, which is also made by the same company, which is the Austin company. They have them in different shape, in different sizes. You can use them in your case according to your defect and how much bone you have to augment. As we can see, this little device, it consists of few things. If you go from the top to bottom, the first part is the healing abutment. And in this case, if we're doing one stage surgery, we can use this healing abutment. If we're using two stage and we want to submerge the whole surgical side, the implant and the bone, we can use the cover cap. Both of them will cover and stabilize the titanium mesh. As you can see, the mesh is made of top area with a big hole. This hole will be mounted on something called the height, and this height has a diameter of 4 millimeter, and the height has few different heights. It depends how deep you put your implant. It goes from 0.5 to 2 mm in the height. It depends on, as we said before, the depth of the implant, how the implant is being placed, how deep it is, and accordingly you can choose your height. All these little parts and tools, you can install them all together, and all the things will be fitted onto the implant. As you can see, it has a thread, this height, the height thread into the implant, and then you put on the top of it the titanium mesh or the builder, and above that you will put either the healing abutment or the cover cap. In order to choose our mesh, we have to go through our bone defect. I did this very simple, easy classification of a bone defect. As you can see, the top side is called the open defect. If we have this open defect, it means that we have to cover the defect from the buccal, occlusal, and palatal side. This is one of the most difficult parts or defects to augment, but it also can be augmented with the same tools. Second one is the self-contained defect. As you can see here, there is a defect on the buccal side, on the occlusal side, but on the palatal side we still have intact bone, as you can see in this our case today. And the third one is called the closed defect. The closed defect, as you can see, we see only there is bone missing on the occlusal surface. There is all other walls are intact with bone, and this is one of the easiest bone defect to augment, as it has blood supply from all over the sides. There is many different ways and techniques to repair bone defects. One common way of doing this, as you can see here on the top, is using a block graft. It's either can be autogenous block graft or allogenic block graft. I used to use this before, and I still use it sometime, but I've noticed that lots of people don't have the tools or the skills to do this kind of block graft, as you have to go through a site and augment a big chunk of bone. You have to use fixation screws, you have to have the right drills to make the holes for the screws, and you have to have the good experience to know how to fix the screws and fix the block and stabilize it, and then you have to augment around the block, as you can see in the picture. One more way also is the socket preservation by using a membrane and bone substitute. Lots of us do this. I usually do this when we have a big defect and the patient is willing to wait. We augment the area, the extraction site. We cover the defects. Sometimes we have a defect on the buccal side, and this is this case, and you just cover it with a normal collagen membrane and fold the membrane over the site, cover the particulated bone or any material that you use. Should be slow resorbing, and you can just cover it and switch it and leave it to heal, and then you can stage your case and place the implant later. Third factor that affects the outcome of the implant's result is the implant position. There is major points we have to take in mind when we place an implant. We have to measure the distance, mesial and distal. We have to measure the distance on the buccal and on the palatal side. As you can see from this picture, on the buccal side we should always have a 2 mm thickness of bone. As we discussed before, if you're placing an implant next to a natural tooth, we should leave at least 1.5 mm. And if you place two implants next to each other, so you need at least 3 mm gap between the two implants. If we don't do this, we will end up having a badly looking gum and the bone around the implant, which will lead to failure at the end of our implant case. And in this kind of measurements, this will guide us when we're using these measurements, how much diameter of the implant we use, in order to determine, because sometimes we all make a flap and then we see the bone and then we think to ourselves, how many millimeters shall I put? Shall I put 3.5? Shall I put 4, 4.5, like this? So if we implement these kind of parameters, it can guide us what diameter implant to use. As you can see in the picture, the gap between, again, the tooth and the implant is 1.5 minimum. Between two implants, minimum of a 3 mm. And as you can see also from the palatal side, we should leave at least 1 mm so we don't have exposure from the palatal side as well. So if we are planning to do an implant in a site, we have to position our implant in the bucco-palatal direction in a proper way. And when we do this, we have to check the diameter of implant and add to it 1 mm on the palatal side and 2 mm on the buccal side. So say that we're putting 4 mm implant of diameter, we should have 4 plus the 1 is 5 plus the 2 is 7. So we should have at least a thickness of 7 mm of ridge from the bucco-palatal dimension. And in the mesiodistal direction, we have to do the same things. We have to have the implant to the tooth, as we mentioned before, 1.5 mm, and the implant to the implant at 3 mm. So when we do an implant positioning, we have to measure all the things, calculate it properly before we start drilling, so we can calculate and determine our diameter of the implant. The third part and the 3D dimension is the apical-coronal position. When we talk about this, we all know from many literature that we have to go 3 to 4 mm below the cement-to-enamel junction, and this is in order to maintain the good gingiva, and we're trying to imitate the biological width of the natural tooth. So we always have to do this. Sometimes we go deeper. If we go deeper, there is also ways to control the gum, and if we do this, we have to know how deep we're going and where to stop, because if we stop at the right place, you can place your implant too deep and then you end up having a recession. So we usually, if we go deeper, we have to follow a way in order to maintain the soft tissue so we don't have a recession. Because sometimes people will get carried away, they put an implant at the extraction site and place it deeper because they want it to be buried in a bone, and then when the healing happened without doing any kind of temporization to the site, the gum resorb and there is no bone supporting it, and this will lead to a longer clinical crown. As we can see in this case, one of my cases that I did long time ago, this patient came to the clinic and she had a trauma, she had a car accident, she fractured her lateral incisor. She had a vital tooth, the incisor was fractured under the bone area, the bone margin, and we had to do extraction we placed the implant and we followed the parameters. We checked the gingiva, it was a thick biotype. We checked the labial plate of bone, it was quite thick, and we augmented as well. And at the same time, we placed the implant in the right position. If we follow these parameters that I discussed before, we get this kind of result. If we look at the papilla on the mesial side, distal side, also in the facial side of the crown on the implant, you can see it is all maintained in one level. No recession, everything looks quite healthy. If you look at this case, also this case came to me to the clinic. Some cases done by some colleagues, and they referred the case to me to ask me what can they do. And in the top case here, you see this is a lady. She's in her 20s. She just graduated from dental school. She asked her colleague to do on her an implant. The colleague did the implant, as you can see, too buccally. If you look on the top picture on the left hand side, you will see that there is position of the implant is being placed too buccally. In the middle picture, you see that after a few months of putting the crown and starting loading the implant, remodeling happened and the gingiva receded due to the resorption of the buccal bone. The colleague tried to cover it. As you can see, he polished the implant and did the graft. It didn't hold, and it resolved. And the final result for this that we had to remove the implant and to do the following factors that we discussed before, and place our implant in the proper side, augment the bone, augment the soft tissue in order to finalize the result. Also, this case on the top right hand side, the implant was placed too deep. As you can see, when it's placed too deep and the buccal mucosa was quite thin, the implant was placed, the crown was placed, and a few months later this happened. A recession happened, the polish surface of the implant is showing, and this is what happens. As we implement this, we see that there is a thin cortical bone. The buccal bone is less than 2 mm. Implant position, if it's done incorrectly, you get this position and you get this failure. And if the biotype is very thin, you find yourself into this position. As you can see here, placing the implant in the proper position and following the parameters, you see the picture on the bottom. This case is done by me. This is a case done referred to me by some colleague. On the top, as you can see the difference where the implant placed in the lower part, where the implant placed in the upper top photo, and you see the proper positioning of the implant was a key factor here. She might have good bone thickness if the implant was placed properly. She might have had quite thick biotype, but it's all went wrong, as one of the parameters for finalizing the implant and reaching good aesthetic result was not followed. Also, this is another case is done by me. As you can see here, this guy came to me with a missing central incisor that he missed when he was a young guy due to some bicycle accident, and he went to some orthodontist who did his orthodontic treatment, and then he was referred to me by his orthodontist to do the implant for the missing central incisor. And as we can see here, we followed the same parameter that we discussed before. The buccal bone was thickened, the soft tissue was measured and it was thin, and it was also thickened, and the implant was placed in the correct position. And after healing, this is what we get the picture on the top. You see a nice healing of the gum. The gingiva did not recede. We have good papilla. We have all the thickness of the buccal bone and the soft tissue looking very healthy. This is another case with the same parameters as well. As we can see, this patient lost his central incisor after a failed root canal treatment. Young guy, he's in his 20s. We did for him the same thing as well, exactly the same procedures. He did some bleaching before he put his final crown. As you can see the results, the level of the gum in proper way, the thickness of the gum on the buccal side, as you can see, is quite thick, and the final result looks satisfactory. And this is due to the same thing, that you have to follow the parameters, you have to follow the guidelines and implement it, and this is what you get at the end. The first thing that we should do straight away as we have the patient is introducing the local anesthetics at the site. We have to check the thickness of the buccal mucosa. And this is usually done by probing. After anesthetizing the site, we check the thickness of the mucosa to the bone. We have a probe with a stopper, and then we probe the area to see how much thickness we have. In this case, we saw that we have a thick biotype. It was 2.1 millimeter after inducing the anesthesia, and we're checking. And then the second step, we have to measure the interproximal distance. It was about 13.5 millimeter. Starting this, I used the Elman dentosurge machine, and I did this because I've noticed that the frenum of the patient is very big and it's reaching nearly the tip of the ridge. So I've decided to do frenectomy in order to make sure that when I do the final closure, there is no any tension, and the muscles of the mouth and the face, when the patient do her facial expression, does not interfere with the site, and to protect the site, to make it completely free of tension. So if you look at this picture precisely, you will see that I'm using the machine to do the frenectomy, and I'm going in a parallel way to the ridge. The reason I'm doing this parallel way to the ridge in order to keep a thick mucosa, as I've seen some colleagues doing this with a perpendicular way, and this leads to deteriorating the mucosa on the buccal side, and later on when the stitch is very thin and it ruptures and it might show the site. And one important thing that we do after augmentation is to have to cover the site properly in order to avoid any fenestration and to avoid any invasion of bacteria and getting infection in the site. So as you can see, I'm trying to go parallel with the ridge in order to keep thick mucosal tissue, and we have a good closure at the end. After I did this, straight away I will suture the area in order to keep the tissue safe and secured after the final augmentation. Now we do a full thickness flap elevation. As you can see, we do it gently. I like to go like 2 teeth on each side in order to have a wide base for the flap. It will help me at the end to augment. As I've noticed that I have a big defect, I have to do lots of augmentation. I have to thicken the ridge by a few millimeters, so I have to make sure that we have a wide base that we can retract it at the end to close the flap without any kind of tension. After we remove the periostal flap and raise the flap, we check the thickness of the ridge. As you can see here, the ridge was quite narrow. It's about 3.8 millimeter of thickness. So as we all know, in order to place an implant, we need some 1 millimeter of bone on the palatal side, we need 2 millimeter on the buccal side. So if you calculate here, it's a 3.8 millimeter, it's very narrow, so we don't have that narrow implant to put it in that area, and even we cannot put the implant in this area less than 3.5 millimeter in order to achieve a good aesthetic result. So I've decided to go for a 3.5 millimeter. So this means that I have to augment on the buccal side to widen the ridge. So if you're putting a 3.5 millimeter implant, we need 1 millimeter on the palatal side, so this is 4.5. 4.5 plus 2 is 6.5 or 7 millimeter. So we need to thicken the bone on the ridge from 3.8 to 7 or 8 millimeter in thickness. I use the template or the suck down tray at the beginning of the case in order to show us or guide us where we're going to place our implants. It's a very cheap way to do this. We don't need to make an expensive surgical guide, and I try to always place my implant in the cingulum area. So the correct position of the implant is a key factor. It's not a matter of where you open your flap and see where is the bone, you place the implant where the bone is. You have to decide the location of the implant in order to receive a final good aesthetic result. So we usually start with a mock-up We look at the mock-up and decide the location of the final crown, and according to this we locate the position of the implant. So in this case we use the first drill to locate our implant position in the correct 3D dimension. This is, you can see the first implant had been located, and if we implement the parameters, we have about even 2 millimeter thickness from the bone, from the distal to the implant position. And then we do the second place, and then I check the site, osteotomy site, make sure that where we're reaching, this is just after the first drill. As you can see, we have a very thin bone on the buccal side on the 2 implant area. I am checking to make sure that I am reaching the proper depth. I am not perforating, or if I'm perforating, where do I perforate it, how do I cover it. All the things you have to do in general when you place an implant. I always inspect the site with this little tool, and in order to check that there is no perforation, there is no frustration, because if there is perforation anywhere and the soft tissue get in touch with the implant, most probably you'll get a failure of the implant. Now, after we decided the proper location and proper drilling, now we'll see the cement to enamel junction, and we decided to go, as you can see here, 3 millimeter below the cement to enamel junction. So this is the third location of the implant that should be placed in the right location and the 3D direction. Now we're going to start placing our implant. As you can see here, I'm placing my implant always in the proper direction. Make sure that when you place the implant that you stay in the right angulation. You don't twist and angulate the handpiece in order to maintain a proper area of implant placement. As you can see here, we decided to place it at the cingulum area, which is the most proper and correct area when you do placement of implant in the aesthetic zone. First implant has been placed and the second implant has been placed, and you can see on the buccal side that the bone is very thin and it's shining through the implant. You can see the grayish color of the implant going inside the bone. We do this at a very low speed in order to maintain the bone intact. We don't drill it with a fast speed to avoid also overheating, and we try to always keep the insertion part of the implant in order to guide us in a parallel way. After the two implants have been placed, and you can see the thin cortical bone and the buccal defects. If you look at the two laterals, you see how much bone they are covered. If you see the implant, it's a very thin buccal bone. So this is what I was talking about earlier, that we have to augment when we see this kind of thin bone. Now we use the bone collector that I was discussing earlier, and I use this one of 5 millimeter diameter. I extended my flap a little bit more to the distal side to just to have one single flap, and as you can see, I've noticed that she has a bit thick bony bulge. I augmented from that area. You can use this in anywhere that you see that excess bone, or you can see that you have enough bone in a specific area. You collect it and you use a very low speed, as we mentioned before, starting at 300 RPM, and then you collect the bone from the side. As you can see here, we collected some bone, and also it's mixed with some blood of the patient. At the same time, I'm gonna start using a mix of allograft with the autogenous bone. As we all know, the autogenous bone is resorbing very fast, so I like to use something to maintain the volume and to maintain the scaffolding of the area in order to facilitate the bone growth in that area. I always do a 50-50 mix. If I use autogenous bone, I always mix it with the corticocancellous mix. This time I'm using it for Putis implant, company, and this Putis company is a German company. They do allograft, and you can use any kind. You can use also the Zimmer bone, They also have the same structure. You can get a cancellous or cortical bone. I use the mix of the both of them together. You mix it with the autogenous bone that has been harvested from the patient, and then we go back to the site, and you can see here I'm trying to perforate the cortical bone in order to gain some blood supply to the augmentation site, and in order to facilitate the blood vessels penetrating that bone, make it thinner, as we noticed before. And I had this problem before. If you use a grafted area and you don't get enough blood supply due to thick cortical bone, or the bone is quite tough in that area, the blood vessel cannot penetrate through, and you don't get enough blood supply, and the augmented area start going in the resorption phase due to the lack of the blood supply. So in this case, I'm trying to use the piezo machine in order just to initiate bleeding from the bone. And as you can see, I'm trying to avoid the site of the implant. You can see the grayish color of the implant shining through the bone. I try to do around it, but not on it, in order to maintain the thin bone covering the implant. After that, as you can see here, we get the mix of the bone of the autogenous and cancellous cortico mix. We mix it together with a bit of blood of the patient, and as you can see, it looks like a sticky kind of paste. We try to place it now gradually on the site, and adapt it in the area properly. And in order to gain, I was trying to gain a shape of the root bulge in that area. As you can see, the first implant had been placed, the first part of the bone has been placed on the first implant, and then we did the second implant, and I'm going to leave this little gap between them in order to mimic the root formed shape in that area. As you can see, we have plenty of bone using that bone collector, and plus you increase the bone with the allographic bone that I used as well. I over augment usually because we expected some kind of resorption in that area, so we over augment, put some extra bone, make sure that if there is some resorption, you will still have enough thickness of the buccal plate, which is 2 mm. So I over augment all the time in order to make sure that even if there is resorption, we still have more than 2 mm on the buccal side. And then we place our smart builder, as I discussed before. We put the height, and then we put the mesh, as you can see, and then we put the gingival cap, or the healing cap, and you can see from the side how much we augmented. It's all augmented in the defect. We're trying to even over augment. You see the mesh is coming more buccally than the rest of the bone, and this mesh should be stabilized well. You can see the border of the mesh is very smooth and curved nicely. You can see the holes of the mesh will allow the blood to penetrate through it, and the blood vessels go through to nourish the site, and to get blood supply to that area. As you can see here, the thickness of the buccal plate, we increased 4 mm. As you can see from the picture here, the thickness of the buccal plate of bone to the implant is more than 3 to 4 mm, as you can see. And even if we get some kind of resorption, we'll still have a big amount of bone on the buccal side. After that, I place a resorbable membrane. In this case, I use something called the it's a biomed membrane. It's a quite thick membrane. As you can see, it's quite rigid as well. You place it, it also makes like a tenting effect at the site, and in the same time it will protect the soft tissue from being exposed directly to the titanium. That might lead to perforation of the soft tissue and exposure of the titanium mesh that might lead to defect in the augmentation area and in the site. So we place this membrane. As you can see, this membrane would take about 8 to 10 weeks to resorb. After getting this membrane in position, we have to fix the membrane, and I use the bone tags It's very simple to use the bone tags. Make sure that when you use the bone tag, you don't hit the roots of the adjacent teeth. It's a short bone tag, so we have also to be careful because the buccal bone usually in that area is quite thick. So we always try to avoid the tip of the roots. Make sure that you are far from it so you don't injure the adjacent teeth. We stabilize it by 2 tags, as you can see in the picture here, and the membrane is folded, and you can see it making a nice tenting effect on the titanium mesh, and it's also covering the area. After fixing it like this at the base, you can flip it open, as you can see in this picture. You flip it open and it makes like a tent. As we discussed before, we over augment because we had extra allographic material, mix it with the patient blood, and then you can see it's all placed to over augment the area, extended to more to the apical side to try to correct the defect. And we use also the PRF membrane that we take it from the patient blood. Sometimes I use it, sometimes I don't use it, but in this case I used it. You take it, centrifuge it, and then you get this fiber membrane that we can place also on the site. It will accelerate the healing. It has natural growth factors. And then we suture the flap after releasing it. As you can see, the area where I did my vernectomy, it's still intact. There is no exposure. There is a thick tissue, so the membrane is covered, the mesh is covered, and everything is in intact way. As you can see that we extended the site, 2 teeth to the distal and 2 teeth to the other distal side as well, and we close it freely without any tension. We try to save the papilla, as you can see, and the patient go home with the suck down tray, and we fill the 2 teeth by acrylic or a composite, and just after the surgery the patient can go home with this tembree. The tembree, this one that we use this suck down tray at the beginning of the surgery to locate the position of the implant. And this is a very cheap way to do this. It doesn't cost much. Any lab can do this. You don't have to be highly technical. It's very easy. You just do a wax up, an impression, and then you build this kind of suck down tray. It will guide you where you want to place your implant. It will guide you also at the end where you want to place your final crowns. As you can see, the patient can go home with the tembree. It doesn't have any kind of pressure on the implant. The patient advised to wear this for a few days and come back to clinic for follow-up to check. And this is when the patient came 5 days later. You see how the healing looks very well. There is no infection, there is no any kind of discharge, all the gum looking well and healing properly. We can see already that we're correcting the bulge on the buccal side, and that defect is nearly disappearing. And I try to, as I said to you at the beginning, I augmented in the area of the roots in order to mimic the nature of the ridge, to have the same kind of appearance to the adjacent teeth. This is the healing after 4 months. The patient had been wearing the suck down tray. We didn't have to bond and rebond and all the things that usually some people do. You see that you bonding and then the bonding come off, the patient buy this one, the patient remove, clean nicely, make sure the implant is clean. She can always brush the teeth properly, and there is no plaque or bacteria accumulated. She always come for follow-ups. We check, we see the stabilizing of the gums trying to appear on the starting to appear on the gum, and then we go back after the healing period in order to remove the mesh. This is a very easy way, as we all saw before at the beginning of the presentation, that the mesh, as I said to you, is all polished and rounded and the edges are very smooth, so it's a very easy to remove the mesh. Is not a critical thing as before. As the old mesh we used to use, when we cut it and shape it, we end up having sharp edges that the bone grew through it, and then you can pull it out. This one doesn't have this problem. We do anesthesia in the area, very simple way, like doing a normal anesthesia, and then we do our incision in a way to save the papilla. As you can see, I do my incision on the palatal side, and we keep the papilla intact in order to maintain a final good result. It's very critical to do this, because if you cut through the papilla, you will damage the papilla, and then you might lose it later on. So I always cut behind the papilla from the palatal side. See, we gently elevate the soft tissue, and now the mesh is starting to show by just removing the healing cap. The mesh is showing on both sides. Now you can see the height. You can unscrew the height as well. Once you unscrew the height become loose. You remove it, and we're starting to see that the height is removed in this picture. You see how much gain of bone we got. We get a big amount of bone on the buccal side. If you measure, it's more than 2 millimeter on the buccal side. This is one of the key factors we discussed, that we have to have at least 2 millimeter. This is more than 2 millimeter, so we are safe in this kind of case. The implant positioned in the proper site, which is the cingulum area. We have a good buccal bone, and we save the papilla. And by gentle moving or twisting mesial distal way, you see you get the mesh removed very easy way, without rupturing the gum, without keeping the soft tissue intact. And you see how much bone we get, and the soft tissue look very healthy, very good keratinized mucosa. The mesh is removed, and this is what we removed. We remove the mesh, and we remove the height, and we have here the healing cap. We place the healing cap again, and suture from the side after removing the mesh. And as you can see, 4 weeks later we get a nice healing, and the area is ready for taking an impression. As you can see from this picture, we imitate the bulge of the root, as you can see on the implant on the right side, implant on the left side, and both of the implant has a good thick mucosa, as you can see as well. They placed in the proper position. We have a good thick mucosa buccally. We have enough bone on the buccal side. The position of the implant is in correct area. So this is implementing all the factors that we discussed at the beginning, and that leads to this result. Now we do the closed tray impression technique. When I put this impression post, you can always put some flowable composite in the area inside in order to show or reflect. Put a flowable composite, light cure it. You can reflect and show the lab the shape of the sulcus. How is the area looking, and how can he produce the same shape in order to support the gum with his crowns. The crowns have been manufactured by our lab. It's a screw retained CAD-CAM crowns. As you can see, the holes of the crown is placed on the palatal side, and we have a nice emergent profile. And then we place the implant at the time of the delivering the crowns, and you can see the blenching of the gingiva. The reason this has happened because we copied the shape of the sulcus, the gingival sulcus, and the crown has been manufactured in a way to support that gingival area from the buccal side in order not to collapse. This blenching should disappear in few minutes. If it doesn't disappear in few minutes, this means that you're exerting too much pressure on the gum. You have to release it by reducing the bulge of the crowns. And this is the day of the insertion, and this is 4 weeks later. As you can see, a final good result 4 weeks later. The gum has healed. The emergent profile of the crown looks very well. The soft tissue all around the papilla looks healthy. It healed nicely, and the buccal bone is still there. And you can see also the stippling of the gum and the nice emerging profile of the crown. The blenching is gone. There is no kind of pressure on any area of the gum, and the gum is free. The bone is still bulging well, so we sort of recover that buccal defect that we started with at the beginning. This is the picture on the top, how we started, and this is the picture at the bottom, how we finished. And just by using this simple way of following the guidelines that I discussed at the beginning, the first steps, we have to diagnose properly, check the gum, check the bone, study the case, take some pictures, look at the case, and then go through the diagnostic steps that we discussed before. How much bone we have, how much gum we have, how much distance we have between the addition teeth, and how many millimeter of diameter implant we should use. And by implementing all the things and following these guidelines, you can always reach this kind of results. And this is how we started at the top, and this is how we finished at the bottom. 4 months later, the patient didn't have to go through lots of surgeries. We did one surgery and placed all the stuff that we need to place. The second surgery was a very small incision on the palatal side. We removed the mesh, very small cut with only 3 stitches, and that's it, which is for a week or 2 weeks maximum. And the patient gained a very good amount of bone. As you can see, we don't have the depression anymore. If you look at the two central, they're actually sticking more buccally than the laterals, so we gain this kind of defect. We cover that area. And if you look here, this is the x-rays, as you can see on the top before we start, and then the bottom at the day of the surgery, and placing, you can see the mesh in the x-ray, you can see the height, and this is the day after we deliver the crown. I usually remove the bone tags because I don't need to cut again the gum. Leave them, they are titanium anyway, they don't cause any problem, and we just leave them there. If they're not causing anything, we leave them. If they showing, we just make a small incision, we cut them. And that time I did not remove them because the buccal mucosa was quite thick. And you can see that we used the platform switching implants. As you can see, the bone has grown above it, that we augmented. It did not resorb, and the area between the two implants is overfilled with the bone, as you can see, so there's no defect in the middle. And this is the patient final smile line with the final crowns. As we discussed before, you see we always follow the smile design guideline. As we can see, the incisor have the right length to follow the lip line, and to follow the dimensions of the laterals. We try to imitate the mamelons on the natural tooth as the patient requested, and this is her final result. So by implementing all these parameters that we discussed at the beginning, it shows us how we can use these very simple techniques, very easy way. You don't have to be very well experienced, because as we all do implants, we all know how to do flaps, we do extraction as wisdom teeth. You can go to that area just exactly as you do wisdom teeth extraction. You can augment bone from that area. You can augment bone from anywhere in the mouth that you think this has some extra bit of bone. That bone collector is very easy to use. It's not difficult, anyone can use it. You just have to place it in the right place and rotate it with the right speed, and then you collect a big amount of bone that you can use in anywhere. Always when you do the bone augmentation, you have to protect the bone in order to stabilize it and let the blood supply reach it in order to facilitate the growth of that augmented area. I thank you very much for your attention.